My job is kind of like the appetizer here for what will follow the main course, as Minnie will cover most of the ligaments of the knee. I'll finish up the day by talking briefly about the anterior cruciate ligament. But I've always had an interest in this particular topic, and what I plan to do over this period of about an hour is to kind of make you guys better detectives as you evaluate the MR examination, trying to sort out mechanisms of injury, which I think really help you as you try to determine what particular ligaments or supporting structures may be torn. But I'm a little bit ahead of myself right now because we're going to actually start with a little bit of some basic information with regard first to the movements of the knee. There are three principal axes upon which movements of the knee are painted. The first one is the major movement of the knee, which is flexion and extension. This, of course, occurs on a transverse axis that runs from the medial to lateral aspect of the knee. The second motion goes by the names of varus or valgus or adduction and abduction, and this motion takes place on that green axis that runs from the anterior to the posterior aspect of the knee. Movement in this plane, of course, far less than movement in the orange plane. The third motion that may take place, again limited at the level of the knee, is motions of external rotation and internal rotation. These motions will take place on that vertical axis painted blue here. If you add to this translational motions that can take place along any of these three axes, I illustrate with the pink arrows only a single axis of translation, you end up with the concept that there are 6 degrees of freedom with regard to the movements that take place at the knee. I want to emphasize that in the middle of that proximal tibia, there exists a bone block. This is the large and elevated intercondylar eminence, and it by itself serves as a restraint to some translational movements, particularly those in a medial lateral direction. In addition, attached to that bone block, of course, are the cruciate ligaments. Now, I want to begin by emphasizing that I consider these to be central collateral ligaments, and if you think of them in that form, it will make sense as we talk about some of the mechanisms of injury. They're not situated real well to be collateral ligaments. To be a good collateral ligament, you want to be away from the central part of the joint. But they do function as collateral ligaments, as I will show you later on in these injury patterns. Surrounding this central tissue, we have a peripheral envelope composed of a lot of connective tissue. We have ligaments, and we have tendons, and we have bands of tissue. These are most concentrated, of course, in the posterior aspect of the knee, in the posteral medial aspect of the knee, and in the posteral lateral aspect of the knee. Very complicated anatomy, which explains why I gave those topics to Minnie to talk about at this particular course. The medial and lateral menisci finally are added to our drawing. We've already talked about them. They serve as cushions between the femoral condyles and the tibial plateau. And when something else is injured, they serve as secondary stabilizers of the joint. During this course, we talked about tendons and we explained the building blocks of tendons, and now I do the same, looking at the building blocks of ligaments. So just as was the case with tendons, we start with small structures, microfibrils, subfibrils, etc., and we end up with collagen bundles within the ligament. These collagen bundles, as in tendons, are oriented along the line of tension, and their job is to resist tensile force applied to the ligament. They are somewhat relaxed at rest, a process called crimp, C-R-I-M-P, but as tension is applied to them, they first straighten out and then they elongate to some degree. There are certain ligaments in the human body that are at risk for injury. There are 5 characteristics of those ligaments. They are listed on this slide, but the only one that I will discuss even any further will be the fact that those ligaments that extend through constricted areas are at risk for injury. The example that I would pick would be the anterior cruciate ligament sitting within the intercondylar notch. There are certain positions of the knee that make that ligament vulnerable to injury. One of these is hyperextension. With hyperextension, that anterior cruciate ligament is jeopardized by the sharp intercondylar roof, and tears of that ligament, shown on the right, can in fact relate to that close relationship. There are 3 patterns of failure within the substance of a ligament. The first of these is a complete tear, where there is interruption of all of the collagen bundles that extend through the ligament, typically associated with transversely or obliquely oriented tears of the ligament. I show you one example of a complete tear involving the anterior cruciate ligament. In certain ligaments, following complete tear in the acute stage, there is a phenomenon called ligament recoil. This is particularly characteristic of the anterior cruciate ligament because of an unusual helicoid arrangement of the collagen. Perhaps it is this recoil that explains the phenomenon of stump entrapment, where a portion of the torn ligament recoils into the anterior aspect of the knee and may present as a blockage to full extension of the knee. The second pattern of intraligamentous failure is designated a partial non-delaminated tear. These are transversely or obliquely oriented tears within the ligament that affect and disrupt certain of the collagen bundles, but not all of them. It is clear that the more of these collagen bundles that are disrupted, the more likely an orthopedic surgeon, utilizing provocative tests, will be able to discern that the ligament is abnormal. The example I show you is a partial non-delaminated tear involving the posterior cruciate ligament, high grade, but some ligamentous fibers are intact. The third type of intraligamentous failure would be a partial delaminated tear. These are longitudinally oriented tears within a ligament that extend mainly parallel to the collagen bundles. On provocative testing, ligaments that contain such tears like this will appear to be stable. These type of partial delaminated tears may result not just from a single injury, but more commonly actually from repetitive stress. And they are particularly frequent in older persons, leading to such terms as cystic degeneration of the ligament, shown here within the anterior cruciate ligament. But the same process can occur in young people, even in athletes, probably related to repetitive stress. The frequency of these in older people with old ligaments, probably a process of ligamentosis, much like the process of tendinosis that we talked about earlier in this course. There are 3 patterns of failure at the attachment site of a ligament. The first of these will designate a peel-back lesion. This occurs when one has a thick ligament or a layered ligament in which there is failure of the deep portion of that ligament. Examples of this pattern of failure would be the anterior bundle of the medial collateral ligamentous complex of the elbow, and that is shown at the top right as that separation of that ligament from the sublime tubercle. Another example would be the anterior bundle of the inferior glenohumeral ligament. We talked about its patterns of pathology. And the medial patellofemoral ligament of the knee, where peel-back lesions may occur. The second pattern of failure, where a ligament attaches to bone, is an avulsion involving the ligament itself, the soft tissue. Here I show you an example of that occurring where the posterior cruciate ligament attaches to the femur. It is important to indicate in your report in these cases that the failure is right at the site of attachment, because these may be repaired relatively easily as compared to ligament tears that occur within the substance of the structure. The third pattern of failure that occurs at an attachment site is a bone avulsion. Many possible examples I could show you. I show you one that I'll talk about later today, occurring at the intercondylar eminence, an avulsion fracture documented by that arrow related to the anterior cruciate ligament. When we look at tensile injury, where ligaments attach to bone, we've made the observation earlier in this course that it is these avulsion injuries that generally produce very little marrow edema. So although we see fractures related to compression and shear quite nicely with MR, the fractures we miss are these avulsion fractures. But the story is a little bit more complicated than that, as there are anatomically two patterns of attachment of ligaments to bone. The first of these are designated direct insertion attachments, and the examples are shown in the parentheses on this slide. Here, the ligament fibers penetrate the cortex of the bone at right angles. In my experience, marrow edema does develop following avulsion injuries of a ligament that has this particular type of anatomic insertion. The second type could be characterized as an indirect insertion. Again, the examples are illustrated or listed here on the slide. Here, the ligament fibers penetrate the cortex at oblique angles, and as shown here with a distal avulsion of the tibial collateral ligament, marrow edema is less common. So this story a bit more complicated than just using a general statement to say avulsive injuries produce little marrow edema. When we look at avulsion fractures about the knee, we can find many, many examples. We can divide these into those that are related to ligaments, the column on your left, and those that are related to tendons, the column on your right. And we can separate them still further by dividing them into medial, lateral, central, and anterior. I am sure Minnie will be covering a lot of these as she discusses the medial and lateral supporting structures of the knee. I'll talk a bit about these as I discuss the anterior cruciate ligament as well. But I would just pick out one to emphasize here, the classic Sagan fracture. We'll return to this subject in more detail later, but this is an interesting fracture, somewhat easy to miss on plain film sometimes because the bone fragment is rather small in some cases. This fracture may relate to the capsular ligament of the knee, as is touted in the literature, but there are a lot of other possibilities as to the pathogenesis of this avulsion fracture. In this case, a portion of the iliotibial tract is attaching to the fragment. The importance of the Sagan fracture relates to the high association with tears of the anterior cruciate ligament, but also because of the high likelihood there are injuries to other lateral supporting structures as well. Now, this is a critical slide of this talk, so I'll take a moment to go through it. Some of the data on this slide are changing, and some of the reported data in the literature are inconsistent. But there are three columns that are here present on this in this table. The first column on your left is that of various motions that can be applied to the knee, and I've listed 7 of those possible motions. In the middle column are the primary restraints or resistance to that particular motion. In the third column, the one on your right, are the secondary restraints, both major and minor, to that particular motion applied to the knee. The reason this is critical information for the radiologist who wants to be a good detective is that when a certain motion is applied to the knee, the first structure that fails is typically the primary restraint, and then injuries to one or more of the secondary restraints may take place. So in that way, we can come up with a sequence of events if we can figure out what motion has been applied to the knee. I'm going to simplify this later in the talk as I give you certain motions and the steps of what ligaments or structures may be injured in most cases. Certainly, these findings are not invariable, and I'm not suggesting that, but this helps you when you try to figure out what structures should be injured. But in order to have it help you, you have to figure out, by looking at the clues, what motion has occurred within the injured knee. To give you one idea how this works, let's take a very common motion that leads to injury of the knee, and that is a valgus motion, which some people would call abduction. As shown in the table, the primary restraint was listed as the medial collateral ligamentous complex, and the secondary restraints as one or both cruciate ligaments. So let's look at the drawing in this particular slide, and you can see I'm illustrating a valgus motion to the knee. In the normal situation, there is contact both on the medial and lateral femoral tibial compartments. When we go to a valgus injury, the point of contact is shifted to the lateral side. This is where compression occurs. The effects of compression are particularly detrimental to articular cartilage, subchondral bone plate, subjacent bone, and the meniscus. So if we have a valgus injury, we would look for compressive findings to those structures in the lateral femoral tibial compartment. To resist the valgus stress, all of those supporting structures located medial to the contact point would come into play. Okay, those would be the medial supporting structures and those central collateral ligaments, the cruciate ligaments. The medial supporting structures act over a longer moment arm from the point of contact to their location on the medial side of the knee. They are the primary restraint. The moment arm between the central collateral ligaments and the point of contact is much smaller. All right? Hence, the cruciate ligaments are secondary restraints to that particular force, a valgus force. These ligaments are put under tension. Tensile force leads to failure of ligaments. Hence, we would look for ligament failure first in those of the medial supporting structures, but never forget to look at the cruciate ligament. The example I show you is that on the left of a valgus injury to the knee, showing you the effects of compression in the lateral compartment with an osteochondral fracture without depression of the subchondral bone plate, and the effects in the medial compartment of low-grade injury to the medial supporting structures, shown as some subtle edema, as well as tensile injury related to the deep medial meniscocapsular ligament, accounting for that little bit of edema in the medial tibial plateau. To complete our observations, the anterior cruciate ligament was abnormal, although not well demonstrated in this slide. So if you are the detective and you see the patterns of marrow edema, you might be able to suspect this was a valgus injury, and therefore you would know where to look for the effects of that injury if you knew the primary and secondary restraints. Okay, so let's take another look at this. During an injury, there are two possible types of force that may be applied to the site of injury. Both may be operational or only one. The first of these is the external or environmental force. This could be a car striking the knee. Worse, it could be a bus or train. I guess that would be a little bit worse. Or it could be the helmet of a player on the opposing team. The red arrows indicate how or the point of contact of that external force. What will occur with an external force is a sphere of influence that classically is located on the surface of the bone. Yes, occasionally it's at the joint level if the force was applied directly there, but more often than not, it is away from the level of the joint. So the sphere of influence and the findings we would see on MR would be those in the soft tissues adjacent to the surface of the bone, those within the cortex, and those within the spongiosa toward the side of the impact force. It is extremely unusual for an external force to involve the end of a bone. So if the vector of abnormality is at the end of the bone, the cause is typically not an external force. The soft tissue abnormalities might go away quickly, but the marrow changes tend to persist. It's hard to predict how long they persist. The information in the literature is not consistent, but certainly weeks, probably months, and maybe even beyond a year. Okay, you might see the marrow edema still persistent. Here's an example of what an external force looks like as you would see it. The red arrow is indicating the site of force application. You can see the edema, which is on that side of the bone at the point of impact. In this case, the edema does not go down to the end of the bone, typical of an external force. So you could look at this if you were a good detective and in fact suggest that this was an external force. The second type of force that may occur during an injury is an internal force, with one bone striking the neighbor. In the knee, the typical scenario is the femur and tibia colliding. But there are other possibilities. If you take a lateral patellar dislocation, it is the patella and femur that are colliding. But most of the time, it is the femur and tibia that collide. The sphere of influence of an internal force is in fact centered within the end of the bone. So here within the cartilage, the subchondral bone plate, or the subjacent bone, we will see the effects of an internal force. Classically, those effects are seen on both sides of the joint, but certainly there are exceptions where we see them only on one side. Statistically, more often than not, we see the changes on the tibial side, not on the femoral side, if one side is involved. As the two bones collide, four potential acute findings may be present within the intervening joint: a joint effusion, a hemarthrosis, a lipohemarthrosis, or most complex of all, a pneumolipohemarthrosis. The pneumolipohemarthrosis is most typically seen in the hip joint, where even gas also is present in the joint, typically associated with fractured dislocations about the hip. The classic example of a hemarthrosis with two layers and one fluid level, serum above and hematocrit below. The typical appearance of a lipohemarthrosis with three layers and two levels, fat, serum, and hematocrit. And as I indicated earlier in this course, the occurrence sometimes of bubbles of fat that float up toward the surface of the effusion, another manifestation of a lipohemarthrosis. As the two bones collide, there are changes that take place in the subchondral bone. We spoke about them earlier in this course, and we talked about bone contusions or bone bruises, kind of a catchy word. The findings are complex, consisting of edema, hemorrhage, and fat lysis, leading to this speckled appearance that we see. When you see bone contusions that dominate in or extend to at least the subchondral bone, you have to consider that in fact this is an internal force. When you see bone contusions that are more dominant away from the end of the bone, you have to consider they relate to an external force, particularly if they are close to one side of the bone. Whenever you study bone contusions, you must look closely at the subchondral bone plate, because subtle depressions of the subchondral bone plate indicate an osteochondral fracture. Later today, in the last conversation we have, we'll talk about the osteochondral fracture in the mid-portion of the lateral femoral condyle that occurs typically with tears of the anterior cruciate ligament. But even this subtle depression, again associated with an anterior cruciate ligament, is a sign not just of a bone contusion, but an osteochondral fracture. Okay, so hopefully you're comfortable with that as the background, and we are going to move on. We are going to go sleuthing over the next part of this lecture. So I looked up the definition of sleuth. It is a word that was introduced many years ago. It is derived from the longer word sleuthhound, referring to a dog, such as a bloodhound, that was used to track or pursue. Synonyms are detective, spy. I don't like snoop because we're not going snooping here, but we're going to do some detective work as we try to figure out mechanisms of injury. In order to do this effectively using the drawings of simple PowerPoint, this is what I will use. You should think of this as a frontal radiograph of the knee. So you're looking at one femoral condyle and a second femoral condyle. It doesn't matter what's medial or lateral. And below it, I illustrate what would be the tibial plateau. So everybody is oriented. This is a frontal radiograph of the knee. Let's look at an external force. Here comes the external force. We'll have it strike one of the femoral condyles. The typical pattern of marrow edema will be confined to a superficial part of a single bone. And although it may extend to the subchondral bone, it dominates away from that extension. So typically, the sphere of influence is at a distance from the subchondral bone. We'll look at this case. We see the blue arrow to indicate exactly where the force was. That is compression. The marrow edema here, yes, it goes down to the subchondral bone, but it is more prominent away from the subchondral bone. This is going to lead to a valgus injury, compression on this side, and tensile injury on the medial side, with changes in the medial supporting structure that Minnie will talk about. So this is the effects of an external force. Ligament failure, often seen in the opposite side of the knee, related to tensile force when dealing with external factors. This leads to three mechanisms of injury, classic ones. A valgus injury, where the external force is applied to the lateral side and there is failure of the medial ligaments. Much less common, a varus mechanism, where an external force is applied to the medial side and failure of lateral ligaments, and then hyperextension, typically associated with an external force applied to the anterior aspect of the knee with failure of one or both cruciate ligaments. So these are the three classic mechanisms of injury related to an external force. We move on to the second scenario, and that is of an internal force. In order to understand this, we have to take 5 separate situations, which are listed on the right. We'll go through each of these separately. The first of these is distraction impaction. The usual mechanism producing this is a valgus injury to the knee, our old friend. What happens with a valgus injury is impaction on one side, distraction on the other side, as illustrated at the top right. So once again, compressive injuries taking place in one compartment, typically the lateral compartment, tensile injuries taking place in the medial compartment. Let's look at this example. I've labeled initially where the edema is and what it relates to. We had a very good history in this particular patient. This is what happened. There was an external force applied to the lateral aspect of the knee at the time of injury, leading to valgus stress, collision with internal force in the lateral femoral condyle and lateral tibial plateau, even a little wrinkling of that subchondral bone plate, and tensile injury to the medial supporting structures of the knee. This is distraction and impaction, a valgus force, the most common scenario. The second of our 5 scenarios is rotation. I will illustrate this by rotating the tibia with respect to the femur. We could do the opposite. We would rotate the femur with respect to the tibia. In general, when we talk about movement of one bone with respect to the other, the convention is to talk about the way the tibia moves anyway with respect to the femur, whether it was the femur that was doing the movement. In any case, I have rotated the tibia. Now we have the injury, and there is a collision with kissing marrow edema, intimate spatially at the time of the injury. But when we go ahead and image this rotated knee, it is no longer rotated. So there is a movement away of those areas of marrow edema on the femoral and tibial side. And the typical pattern we see about the knee is marrow edema more anteriorly located in the femoral condyle than it is in the ipsilateral tibial plateau. Now, I'd love to tell you this was specific for rotation, but it is not. But I always think of rotational injury when I see this pattern. An offset in marrow edema. In this case, clearly a displaced tear of the lateral meniscus is also seen. So when you have marrow edema on one side that is not intimate with the marrow edema on the opposite side, and it relates to internal force because it is located in the subchondral bone, one of the mechanisms of injury may be rotation. In this case, by history, it was internal rotation of the tibia, something called ALRI, anterolateral rotary instability, a very important cause of tears of the anterior cruciate ligament. This is the classic mechanism of a Sagan fracture. So if you see a Sagan fracture, you can be fairly certain you're dealing with an ALRI mechanism of injury. The third of our scenarios is flexion. I'll illustrate this by flexing the femur with respect to the tibia. It could be the opposite. What occurs now during the injury is a collision of the femur and tibia, intimate spatially, at the time of injury. But when we image this flexed knee, it is no longer flexed. So here, the injury. Here, the position of imaging. There is a shift in the pattern of marrow edema. Now, that in the femoral condyle laterally is a little bit rotated posteriorly away from the edema involving the posterior aspect of the lateral tibial plateau. This is the classic pattern of injury that occurs in a skier, and I'll talk more about this in my final talk, when you have flexion and valgus injury, allowing collision of these two portions. This is associated with tearing of the anterior cruciate ligament, mainly related to the activity of the quadriceps mechanism, as I will explain. So in any case, this indicates flexion. Injury of non-contiguous portions in the subchondral bone of femur and tibia can indicate rotation, flexion, and in addition indicates usually multiple ligaments are injured and there are meniscal injuries. This leads to 2 classic mechanisms of injury: flexion, varus, and internal rotation, known as ALRI, anterolateral rotary instability, in which we get injury to the anterior cruciate ligament and lateral ligaments. Think of a Sagan fracture. The second, flexion, valgus, and external rotation, leading to AMRI, anteromedial rotary instability, with injury to the anterior cruciate ligament and medial ligaments. The classic example, O'Donoghue's triad. And I think both Minnie and I will be talking a bit about O'Donoghue's triad. The fourth of our scenarios is hyperextension. And in order to illustrate that, let's change this from a frontal radiograph to a lateral radiograph. So you're oriented, femoral condyles above, tibial plateau below. The typical scenario of a hyperextension injury is a direct external force applied somewhere to the anterior aspect of the knee. So we would expect to see the effects of the external force on the anterior aspect. It may be in the femur, it may be in the patella, but it would be something located anteriorly. This will throw the knee into hyperextension with contact of the anterior aspect of the femoral condyle and the anterior aspect of the tibial plateau. The identification of marrow edema, and even better, of fractures involving the anterior aspect of the medial or even the lateral tibial plateau should always raise concern you are dealing with a hyperextension injury. And if you know the primary and secondary stabilizers, you would then know to look at the cruciate ligaments and the structures in the posterolateral corner of the knee. I'll show you an example. The images weren't good, but the story was good. We had a complete history. This was a patient who remembered clearly he was struck just above the patella right here. Subtle edema is seen in the anterior portion of the femur on this STIR image due to the external force. The knee was thrown into hyperextension. Now we see the effects of the internal force on the anterior aspects of the femoral condyle and tibial plateau. This patient did have cruciate ligament injury, and the detective could figure out that this was a hyperextension injury. The final scenario is translation, anterior translation typically, and this is a little bit more complex because as the tibia translates, typically there is increasing flexion at the level of the knee joint. With straight anterior translation of the tibia, there is often contact between the posterior aspect of both tibial plateaus with the mid portions of both femoral condyles. Now, clearly there are variations where the edema will be more profound laterally or medially. But if you see marrow edema in this pattern in both sides of the knee, you have to consider anterior translation. Now, here's an example, and I'll indicate the controversy regarding it. This is what I would look to for a pattern of edema that might suggest pure translation. On the medial side, we see that the marrow edema in the medial femoral condyle is more anterior than the marrow edema in the posterior aspect of the medial tibial plateau. Similarly, on the lateral side. And typically, as you look at this, the marrow edema tends to be closer together on the medial side than it is on the lateral side. Now, a lot of people look at this same pattern of marrow edema and say this is rotational. The knee rotates to one side, and then there is a contra-coup effect as it over-rotates to the other. But I think that contra-coup effect is overrated in the literature. I think this pattern of edema can occur with anterior translation alone. So we put it all together and we end up, in fact, with a chart that looks like this. Let me explain this. You can see two columns, external force, internal force, and four groups of ligaments or ligaments, anterior, posterior, cruciates, medial and lateral supporting structures. Let's take the typical scenario of an anterior cruciate ligament tear. Statistically, more commonly, these relate to internal force alone. Let me give you a good example. We'll take a professional football team and we'll make it the San Diego Chargers. And if the San Diego Chargers were ever to be good, they would need a very, very dominant running back. They've had one in the past, not so right now. And if you have a good dominant running back in American football, that person has to be strong and fast, certainly. But more than that, has to have good vision, right? So think of this very good running back running down the field with a San Diego Charger uniform on, okay, with good vision. And out of the corner of his eye, he sees the opponent racing toward him. But he has good vision and he's quick. And so what he does is pivot, all right? And he avoids the tackle. But as he pivots, he hears a snapping or cracking in his knee, and he has torn his anterior cruciate ligament. All right, internal force would then be generated. No external force, but the anterior cruciate ligament has been torn. Or the posterior cruciate ligament, the person sitting in the front seat of a car. The car stops, the person doesn't. The knee strikes the dashboard. The tibia driven back. External force, the main indicator in a posterior cruciate ligament. And then in the medial and lateral sides of the knee, both external and internal force. So that's the story told save one feature. And that is what happens with a pure distraction injury of the knee. You know, a pulling apart. All right, what is going to happen in this scenario? And I have a case that I will show you. It happened to a person who worked as a doctor at one of our affiliate hospitals, and after his injury, I sat down and talked to him for a long time, so I know the mechanism of injury. So let me tell you his story. It will take about a minute, all right? This is a 42-year-old male rheumatologist. But what he remembered about this particular injury was that he felt like his knee was being pulled apart, distraction. And when we looked at his MR images, and here they are, there was high-grade tearing of many of the medial supporting structures on your left and high-grade tearing of the anterior cruciate ligament on your right, and yet we couldn't find a bone contusion. So if you see a lot of ligament injuries without marrow edema in the acute or subacute stage, consider the possibility of distraction as the mechanism. So we have about 20 more minutes, and we're going to do two more things. I'm going to first try to summarize, maybe simplify these injuries. And I came up with this diagram. So the orange here, that rectangle, is the femur. This circle in white is the tibia. And I've added in green all of these supporting structures around the knee, to the right being medial and to the left being lateral. And what we try to do as good detectives, or sleuths, is to use the marrow edema to kind of predict which way the tibia moved with respect to the femur, translation or rotation. And if, in fact, we do this, there are these particular possibilities. One can have abnormal anterior translation, abnormal posterior translation, two forms of distraction, valgus and varus, and four patterns of rotation, rotational injury of the knee. We've talked about Alry and Amry. These others are less common, and I'm not going to be covering them in detail. So let me show you some of the patterns. The first of these, anterior translation. There are four stages of injury to the knee. The first structure that typically fails is the anterior cruciate ligament. The second, portions of the medial and lateral supporting structures. The third structure is the posterior capsule failing under tension. And then the fourth, possibly the posterior cruciate ligament. So that is the sequence of events classically described with an anterior translational injury of the knee. Another example, posterior translation. With posterior translation, there are two stages of injury. The tibia moves posterior, as shown here. The first structure that fails is the posterior cruciate ligament, and then the posterior oblique ligament and other structures in the posteromedial corner, and the arcuate ligament and other structures in the posterolateral corner. The third pattern is medial distraction or valgus injury. Here there are three stages of injury. The first failure is that of the medial collateral ligament and posterior oblique ligament. The second stage is injury to the secondary restraint, the anterior cruciate ligament. and the third possibly to the posterior cruciate ligament as well. Or let us look at lateral distraction and varus, which is a rare injury. 3 stages of injury. The first of these is injury to structures on the lateral aspect of the knee. And you can see them in red in the diagram now. The second stage is injury to the posterior cruciate ligament and posterior capsule. And the third, possibly injury to the anterior cruciate ligament. And then finally, 2 patterns of rotation. Here we have anterior translation and internal rotation of the tibia. The structures injured with this mechanism, ALRI, the anterior cruciate ligament, and the lateral supporting structures. Or the opposite, anterior translation and external rotation of the tibia. The structures injured there, the anterior cruciate ligament, and the medial supporting structures. Now let's go one step further. There are these classic ligament injuries of the knee, and I've listed them there, okay, and there are a whole bunch. Some of these relate to contact injuries, some relate to non-contact, some are caused by either type of injury. What I want to do in the last 10 minutes is to discuss and show you examples of 6 of them. So we're going to look at these, and the way I'm going to do this is to give you very accurate histories of cases that we've seen and show you those MR. But I'm going to supplement it by going on the internet and showing you pictures of that particular mechanism at work. So there is a disconnect from the internet picture. You're not looking at the MR images of that particular person, just in case you recognize some of those internet pictures. We'll use this kind of Venn diagram, ACL, PCL, medial and lateral, and then various overlapping of them. Okay, so let's look at 6 of these. The first of these is a pure valgus injury, and I'm showing you the normal position here and what happens with a valgus injury here. All you have to think about in cases like this is where is the tensile injury and where is the compressive injury. Tensile injury leads to failure of what? Of ligaments. And remember the meniscus failure I showed you, which was a corner tear of the meniscus. That's what I'd expect to see on the medial side. On the lateral side, compressive injury to meniscus, cartilage, subchondral bone plate, and subjacent marrow. Now here are possible mechanisms. You look at the top 2, and I've skied for years, and I can remember with fear looking down and seeing my skis like this many, many times. Probably some of you remember the snowplow going afoul, where the legs keep going apart. This would produce a valgus stress of the knee. Or this, which is my all-time horrible look when you look down and you see your skis like that. I can't be the only one that this brings back bad memories, all right? But if in fact that happens, you fall over this knee, that would be a valgus stress to the knee. You can see in American football how this would happen if someone struck the knee like that, just about or just above the level of the knee. Oops. So what we see here is the story of a 24-year-old semi-professional American football player. He was struck on the outside aspect of the leg, just above the knee, with the joint slightly flexed. So here is the external force above the level of the knee, lateral side, tensile force leading to injury of the ligaments on the medial side. This is the picture of a valgus injury. The second of our 6 scenarios is posterior translation. We'll use this drawing of the normal lateral picture of the knee, and here's what happens with posterior translation. The tensile injury occurs mainly in the posterior 2/3 of the knee, the compressive injury in the anterior 1/3. The ligament typically that is torn is going to be the posterior cruciate ligament, next most likely lateral supporting structures, and then various combinations may be seen. We can think of this as a possibility in American football where the helmet strikes the knee just below the level of the knee, driving the tibia back. The example I would show you is that of a 23-year-old woman who suffered a high-speed head-on automobile accident during which her knee struck the dashboard and she dislocated her hip. You can appreciate here the external force has damaged the patella and the patellar tendon. Tensile injury involving the posterior cruciate ligament and even the popliteus muscle and tendon were abnormal. So this is posterior translation. The third of our 6 mechanisms is anterior translation, a common mechanism. Here what happens is that the tibia moves forward. Tensile problems on the anterior 2/3 of the knee, compression problems in the posterior 1/3. The typical scenario is failure of the anterior cruciate ligament most often, and sometimes failure of medial and lateral supporting structures. Excuse me. The typical skiing mechanism is called the boot-induced mechanism. Maybe you found yourself in this particular position on the ski slope. Here's the story. It's a 42-year-old recreational skier, lost his balance during a jump. The tail of the downhill ski hit the snow and pushed the back of the boot against the calf, causing the ski to begin to run very fast anteriorly. He heard a pop, that dreaded pop, and he fell. And as you look at this, you can see that he developed injuries here to the anterior cruciate ligament. The posterior cruciate ligament was actually all right, and he had injury to the popliteus muscle as well. Now, this is an interesting mechanism, this boot-induced mechanism. So let me use this particular diagram. It's very well known with skiing. You're looking at the lateral femoral condyle, the medial femoral condyle, the quadriceps mechanism or extensor mechanism, and the patella. So this is the typical mechanism for a boot-induced skiing injury. What occurs, in fact, here is a major pull on the quadriceps muscle. The quadriceps muscle tends to push the tibia anteriorly. So it is an antagonist to this ligament, which is the anterior cruciate ligament. So as the quadriceps muscle activates during this boot-induced injury, there is going to be a tear of the anterior cruciate ligament. This is a classic injury that takes place in the skier. The fourth of our 6 scenarios is pure hyperextension. Here is the drawing of the normal. This then is what happens to the knee in hyperextension. All you have to do, again, is figure out where the tensile force is and where the compression force is. The tensile force dominates the knee with hyperextension, occupying the posterior 3/4 of the knee. The compressive force is found in the anterior 1/3 or 1/4 of the knee. So you look for compressive injuries in the anterior quarter, fractures, some meniscal pathology, and you look for tensile injuries that can occupy both cruciate ligaments and particularly the posterior horns of the menisci. The scenario typically is injury to the anterior and posterior cruciate ligament with possible injuries, as shown by these overlapping circles, less common, to other structures as well. The rotation along this axis, a medial lateral axis. The example I show you derived from the internet. The picture on your left, a teenage girl hyperextended her knee during a soccer game when she completely missed the ball on what would have been the winning goal. In this example, with that history from our practice, the main finding we saw related to hyperextension was this offset marrow edema noted anteriorly due to the contact of the femoral condyle and the tibial plateau. So bone damage anteriorly. Anterior aspect, medial tibial plateau, anterior aspect of the lateral tibial plateau, very important. And finally, rotational injury, and we'll finish up in the next 5 minutes with this. There are certain rotational positions that make the cruciate ligaments at risk. This is the neutral. You can see that when we do internal rotation of the tibia, we entwine the cruciate ligament. So theoretically, internal rotation of the tibia is a very damaging change in orientation for the cruciates. Actually, external rotation is not, yet we clearly see injuries to the cruciate ligaments with external rotation. It unwinds the cruciate ligaments. There are four major rotational injuries of the knee, which are outlined here. Two of these relate to internal rotation. Two of these relate to external rotation. Two relate to anterior translation. Two relate to posterior translation of the tibia. We will not discuss these two today. They are less common, although they are important causes of injuries to cruciate ligaments and posteromedial and posterolateral corner. But we'll finish up again by looking at these two common patterns, ALRI and AMRI. And to give you an idea of what these look like, from the internet, I took these two pictures. If you have an American football player who has a planted foot and he cuts toward the planted leg, the movement is internal rotation of the tibia with respect to the femur. If you take an American football player who plants the leg and then rotates away from that leg, the movement will be external rotation. So both of these rotational patterns are seen in many sports, including American football. Flexion varus and internal rotation, movement along these three axes as shown. This is what happens. The injuries tend to occur where the tensile force is anterior cruciate ligament and lateral supporting structure. The example I would show you, the history, this star halfback for his high school football team, he cut around a would-be tackler, and just as I said in my scenario earlier, he avoided him. But in avoiding him, he heard a pop, tearing his anterior cruciate ligament. We see the tear, we see the Sagan fracture, classic ALRI mechanism. And finally, the last one, flexion, valgus, and external rotation. This is common in the knee, particularly with an external force, but sometimes without an external force. What we see injured here will relate to tensile abnormalities in the central and medial aspect of the knee, typically injury to the anterior cruciate ligament and to the medial supporting structures of the knee. And again, O'Donoghue's triad comes to mind. The example I show you, this 24-year-old college quarterback was hit from the side just above the knee as he attempted to complete a pass. This is the external force, like we've talked about, shown here by orange. You can see he had dramatic changes in the medial supporting structures. Many will be talking about these, and tearing of his anterior cruciate ligament. So you can come up with Venn drawings just like this. I don't have these alongside our viewer, and I don't know all of the information on these drawings, but they're useful. And if you are, in fact, a good detective, a sleuth, you will look at these images now with new meaning. You'll use marrow edema to help you decide on the force applied to the knee at the time of injury, and then with information you've learned regarding primary and secondary restraints and compressive and tensile portions of the knee during that movement, you'll be able to figure out what structures should be injured.